Pharmacology Case Study, Group 1, Hayden Burke, Rachel Lindsay, Lisa Thino, and Beth Beach. History of present illness. KL is a 17-year-old Caucasian male who presented to clinic on 4/10/2012 with a chief complaint of increased seizure activity times 1 week and pain. On 4/3/2012, KL had 4 seizures. The length of the seizures ranged from 10 minutes to 1 hour. He has continued to have 1 or more seizures per day. KL's pain medications do not seem to be as effective as they have been in the past. Nothing seems to be making the seizures worse, and pain medication and lorazepam do help the seizure activity but do not stop them completely. There's been no change in his elimination or diet tolerance, but his sleep has been affected. Past medical history. In 1995, at 3 months of age, KL suffered neurologic devastation secondary to a severe hypoxic encephalopathy following a nipple aspiration at his home in Edmond, Oklahoma. KL's aspiration led to full cardiac arrest. He was pulseless and apneic for an unknown period of time when paramedics arrived at his home. KL was resuscitated, intubated, and transported to OU Children's Hospital, where he spent 6 weeks. It was at that determined that his family would be unable to care for him at their home. He was then transferred to a long-term care facility, where he has resided since. The decision was made to make KL an A&D in 1995, and that status remains active today. Previously, he was on Dilantin. That was discontinued due to severe gingival hypoplasia that caused severe airway compromise, requiring a tracheostomy to be placed. He was also previously on Depakote. That was discontinued due to elevated serum concentrations. His past surgical history includes a G2 placement with fundoplication, tracheostomy placement, vagal nerve stimulator placement, right myorotomy with tube placement, and removal of a vagal nerve stimulator because it was no longer working. Past procedures and diagnostics. He has received Botox and phenol injections in his lower extremities, and he has had annual DECA scans since 2005. His last scan was in January of 2012. And because of his known seizure disorder, he has periodic EEGs. Personal social history. KL is a 17-year-old male living in a long-term care facility. He attends activities regularly at the facility. He is also in special ed classes that meet once a week, and he receives PT and OT every other day. His family does visit him in the facility approximately 2 to 3 times a year. His family history includes his mother has environmental allergies, brother with asthma, maternal grandfather with hypertension and hyperlipidemia, paternal grandmother with hypertension, and the family denies any past medical history of substance abuse, seizure disorder, heart disease, or cancer. Socioeconomics. KL receives SSI monthly, and that covers therapies and non-formulary medications, and his primary insurance is Medicaid.
Physical exam. On exam, KL is awake and alert and sitting in his wheelchair. He appears well hydrated, non-toxic, and is in no apparent distress. He is microcephalic and atraumatic. His eyes have slight redness because of his inability to close them. He has no drainage. Sclera and conjunctiva are clear. TMs are pearly gray with good light reflex and normal landmarks. Nares are patent with no drainage. His oropharynx is not visible due to severe gingival hyperplasia. He has no oral lesions. Mucosa is pink with the use of biotin. Trach is midline, patent with thin, clear secretions, and he is receiving oxygen per trach collar. KL has a regular rate and rhythm, normal S1, S2 without murmur, rub, or gallop. His peripheral pulses are 2+ and equal bilaterally. He has no edema and brisk capillary refill. His abdomen is round, soft, non-tender, non-distended, without hepatosplenomegaly. His bowel sounds are normoactive in all quadrants. He is a Tanner 2-stage male. KL is non-ambulatory per baseline. He does not move his extremities except for during seizures and when he has spastic tremors in response to pain or touch. He is hyperreflexive and has contractures to his wrists bilaterally. He also has a 30-degree foot drop noted bilaterally. He has no deviation of his spine. He is neurologically devastated after a severe brain injury. He has no seizure activity during exam, and he responds to bright light, pain, and loud stimuli. He has no gag reflex. His skin is pink, warm, and dry. He has no rashes, lesions, or pigment changes.
Labs and diagnostic testing. The following labs were collected on 3/20/2012. KL's labs were not fasting, and his medications were held prior to checking levels. His creatinine was verified by repeat analysis.
A chest x-ray on January 21st showed bilateral lower lobe infiltrates indicative of pneumonia. His pneumonia has since resolved, but bilateral bases remain diminished. A DEXA scan showed improvement from prior scans prior to the initiation of pamidronate therapy, but results were still consistent with osteoporosis. Anticonvulsants were not held prior to this EEG. KL's medical diagnoses include hypoxic ischemic encephalopathy with anoxic brain injury following aspiration, microcephaly with spastic CP and severe mental retardation, symptomatic epilepsy, osteoporosis, and chronic pain. Additional medical diagnoses include chronic constipation, GERD, tracheostomy, GT-dependent, and palliative care. KL's scheduled medications include Onfi, phenobarbital, Klonopin, Keppra, Ativan, and morphine. Methadone, baclofen, calcium carbonate, pamidronate, lactulose, and Miralax are also part of KL's daily medication regimen.